Thank you very much for inviting me to speak in this very interesting session, and thank you for allowing me to speak earlier. I have double booked. It must have escaped someone in the program committee. So the title of this talk is Empowering the Person. Let's look at it bit by bit. When we speak about the person, who are we actually referring to? Who's the person in this photo? I think that they are all persons. I think this gentleman here is a physician, is a person. I think the nurse is a person. I think the family member is a person. And I think the person who is affected with the condition is also a person. So in this photo, this is actually the cell of resistance to the progression of a tough disease. And what we need to identify from the start is that those four components should coexist, co-work, and cohabit this condition and try to figure out how to best serve the interest of the person as well as the community. So let's focus on the first person in a white coat, the ophthalmologist here. And I think the best way to empower an ophthalmologist when he's managing a glaucoma condition is by educating him. And there are different types or different sources of education. We all have our mentors, our teachers that we have followed in their path and learned from them. There's auto-education. It can be in the form of an ophthalmologist reading, accessing information on the internet, or going into PubMed, or looking at his own records to learn from his triumphs and his failures. But I think that probably one of the most important sources that is not utilized at all, in my opinion, is education through patients. Of course, there's indirect education. That is, we see the patients, we observe the patients as ophthalmologists, and try to, if we are clever enough, to learn from them. And this is a sort of an indirect education. But I think what we should emphasize on is direct education. I believe that it's, in that day and age, it should be mandatory for young residents and ophthalmologists to get education about glaucoma from patients. We should actually listen to them. We should be in a meeting like that, listening to the patients tell us about the disease. Because what we know about the disease might be very different from their side of the story. Well, we sometimes are bombarded with targeted education. Targeted education is not always that innocent. A few years ago, there was a huge explosion in ophthalmic education about dry eye syndrome and the eye drops and the glaucoma eye drops. And that was true. I mean, there is a predominance of dry eyes among glaucoma patients, and it increases if the patient is taking eye drops. But that has always been driven, at least in the last couple of years, by the industry trying to go for non-preservative or back-free drops. And that sometimes can overemphasize something while taking from the valuable time of an ophthalmologist as he tries to get educated, tries to get better. So I'm not very big on this kind of education. And I think that the World Glaucoma Patient Association, the World Glaucoma Association are a credible, as you might have seen in the last couple of days, way of getting an education. And I think that is what we should accentuate. Education should be given to educators without the financial and marketing interest. Okay, let's go to the second member in the photo that we were discussing, the nursing staff. And I think this is why I've been invited to this session, because we have been working hard over the last 4 years in Geneva, in where I practice, on empowering our nursing staff. So the project that took from start to fulfillment, let's say about 2 years of work, was about teaching or creating a consultation for nurses to educate the patients about issues related to glaucoma, to get feedback from the patients, and at the same time to provide assistance in the forms of material, in the forms of evaluation of how the patient is applying his eye drops. So it has been quite a thrilling ride for me, and I enjoyed very much working with the nurses over 2 years, giving them regular education or regular courses about what is glaucoma, taking them into the operating room, having them with me all the time while I'm consulting. It's an expensive endeavor because we're always lacking resources, but it pays off. From the data that we collected, our patients are quite satisfied when they have a half an hour with a nurse that actually discusses issues, constraints, problems with quality of life. The nurse would film the patient as he applies drops in the eyes and would show him how good or less good is he in applying eye drops inside the eye. It works very well. Now, of course, this is an issue of resources, and I had to fight extremely hard in an industrialized economy like Switzerland to get the resources to have a nurse working 100% of time at the service of the persons with the condition, but it works. So it goes into steps. Increase the knowledge of your staff. I think this is very important. Provide them with tools that can be in the form of devices, in the form of brochures, in the forms of small video clips. They should have clear messages about how to communicate with people with glaucoma. And after all that, you have to be there for them because they will not have all the answers, and they might encounter a question that is difficult, and they should have access to you as an ophthalmologist to answer some of those questions. So you do not leave them in nature and ask them to face such challenges. It's a training process. What we also did in Geneva was not to train one nurse. We trained all our nurses. All our nurses in ophthalmology were trained equally so that we are not, we do not have to keep on using the same nurse all over and over, and at the same time, the amount of knowledge disseminated among all nurses worked very well for us. Now let's look at the third person in the photo, here, somewhere. This is the life partner, a friend, family member. And in our population in Geneva, we published a work by one of my fellows, Shibal Bhartia, who found that in Geneva, 78% of patients had their drops instilled by a life partner, not by the patient himself. A good number of our patients now, or a good number of our families and life partners of people who have glaucoma have been acquiring pressure tonometers and have been helping their life partner in measuring the pressure. It's not something that is widely spread, but it is something that is happening. I'm now getting people buying tonometers at home with technologies being now available, measuring pressures for their life partners and reporting to us. And those are people, I think, that deserve ultra special consideration. They have to contend with all the stresses, sometimes depression, sometimes moody changes in moods of the people affected with glaucoma, and they deserve our support. So our support should not, as all doctors, we should not privilege people with glaucoma with our care, but the care that we are providing should extend to their life partners, to their close friends, and to their family members. Now let's discuss the person with glaucoma. So the person with glaucoma should be informed about the condition. And this is a small series of photos that we have worked on in Geneva with our Belgian colleagues. They basically try to explain what is glaucoma and how it can affect a patient's quality of life. Here, it accentuates on the capacity of the patient to drive and speaks about about cerebral plasticity and why a person with glaucoma might not be able to feel or to detect symptoms related to this condition. It works very well. We have one of those in every examination clinic in the University of Geneva Ophthalmology Service. It helps residents as well explain about the condition. I think it's fundamental to make sure that the patients understand what is glaucoma. And in one paper that we published comparing Swiss Germans to Swiss French in relation to their ability to be compliant with medications, we found, to my dismay, that a risk factor for being non-compliant was living in Geneva. And despite the rates of compliance being relatively low compared to other countries in Europe, which was relative, I mean, the Swiss with their punctual watches were in a very good bracket when it comes to compliance. We found that our patients comply very well, but their understanding of what glaucoma is was very bad. So we found that Greeks know very well about their glaucoma, but don't put drops. We found that the Swiss put their drops, but know very little about their glaucoma. And I think this is our failure as health providers, and it's something that we should tackle. So a patient should be informed about the condition, as we said, and should be able to understand why we're giving this therapy and challenges related to giving this therapy. As I was working 5 hours ago in my hotel room, trying to finish this presentation, and being a member of some of the support groups, patient support groups on social media, I came out, I saw this yesterday, so that was 8 hours ago. David, a guy suffering from glaucoma, has been asking other patients in the group, my eyes always itch, is this normal? It's very sad that he actually did not get a reply to that from his health care provider, from his ophthalmologist. He has to resort to asking 5,883 members of this group about itchy eyes. Why aren't we telling our patients that a drop can cause an itch in the eyes? Are we actually overburdening our patients? This is... I'm sorry, can you pick up the sound, please? This is one of our patients who is in the era of monodoses, is struggling to use one of those monodoses. Just over there. Yeah.
Il est dedans?
Oui. And as you can see here, her hands in that age is not as nimble as it was many years ago. And it is not easy. In many cases, abrasions can happen. So ask yourself, are we overburdening our patients, asking them to do things that they are maybe incapacitated or unable to do? Every time we prescribe a monodose in Switzerland or in Geneva, we give an artificial tear monodose to the patient and test how he or she is managing with it before sending him with a prescription, not knowing if he will be able to manage it or not. And we should educate them also about risks without creating panic. But we should explain things like that cataracts can happen from a glaucoma surgery in 20% of cases, and that when you go to a glaucoma surgery, you might lose some vision. These are things that I believe are not discussed enough before we take the patient to the operating room. We should speak about that even in the best of hands, complication rates can be high, and patients should really be making an informed consent, a true informed consent, before he signs for a glaucoma surgery. Horror stories like a 6% loss of central vision could be mentioned in advanced glaucoma. I mean, you cannot really, in all fairness, take a patient to an operating theater and not mention that there is a very, very small risk of loss of vision. We should not make it like a walk in the park. I mean, patients should understand the pros and cons of going into surgery. But the good news is glaucoma can now be cured. So again, at 4:30 in the morning, a few hours ago, I was on my mobile phone. So this is not 9:36. This is 9:36 Geneva time. So I think we should all pack our bags, think of doing refractive surgery probably, because according to the Mail in its issue of yesterday, glaucoma can now be cured with a simple injection. And that is according to eye surgeons. This is a widely spread and widely read journal, for those of you who don't know, in the United Kingdom. So according to the journalists, a tube injected into the eye can now allow excess fluid to drain out to relieve pressure. And this is addressed to the 600,000 Britons suffering from glaucoma, that this new injection treatment is hailed as the biggest breakthrough in years. Fantastic. And I was wondering what kind of a procedure. I know glaucoma surgery fairly well. So when I saw that the diagram, it's something I've been practicing for a couple of years, not that I would call a cure for glaucoma, and not would call a huge breakthrough. It's again injecting something in the eye. Some people call it a Zen implant. And our colleague from the Royal Free Hospital in London has been quoted as, it was quicker and safer than current methods. I'm not aware of any comparative trials between a Zen implant and any other device. My understanding is that this device has been tested for the time being in prospective, non-randomized fashion. I'm part of one of those studies. So a claim of being quicker and safer is of interest. Be happy to see how that can be backed. To be honest, we are just seeing what is written, and we have no clue if this has been actually said. But if it has been said, I would probably like to ask for an explanation, or better still, retraction from such claims. So a person with glaucoma should be informed, not misinformed. And you know that now, a patient suffering from glaucoma is actually getting more information from social media and from internet than from you, surely. So whatever is put on the social media and on websites has to be treated with utmost respect for the person that is suffering with glaucoma. Patients, groups, glaucoma patient organizations, Glaucoma World Association should take the lead in providing credible information to people or persons suffering from glaucoma. And we should not let them fall into the hands of such claims that, to use a major understatement, is audacious and preposterous. You have been maybe seeing that I've been using the word person and struggling when I use the word patient. And every time I use patient, I feel that I did something wrong and go back in what I'm saying. And that is because I would like to challenge you as you take your flights back home to think of the implication of calling a person with a condition a patient. As a young physician, that was many years ago, I was never very comfortable with calling people with diseases patients. It depends on where you're practicing. There are cultural issues involved, obviously. But I think in the photo that we saw with the 4 partners providing care, when we stigmatize or take one of those 4 out of the equation and stop calling him a person and start calling him a patient, this has implications. This is something that I have been studying with our Department of Psychiatry in Geneva for years. Hopefully, at one point, we'll come up with some recommendations and conclusions. But at this point of time, I have to say I don't like the word patient. And I would like to stick with the word person with a condition. This is not an overly political correctness like what is practiced sometimes in some places around the world. But it is at least a personal feeling or interest or attitude that I think we should all at least consider. So, to end up this, and I hope that this was not terribly boring for you, I think that to provide better care to a person suffering from glaucoma, we should empower not just the person, but all the groups of people involved in his care. Because if we actually spend time doing that with some real heart and interest in what we're doing, the impact of that on the quality of life of the person, as well as the overall health of the community, is going to be the biggest winner. Thank you very much for your attention.